Our discussion tonight will start with an overview of regenerative medicine. We'll explore the different types of orthobiologics, discuss who the candidates are for these types of therapies, and how patients can access them. Following the overview, we'll transition into a focused discussion aimed at getting to the myths and offering clarity on musculoskeletal biologics. So tonight, I'm happy to introduce our speakers. Sorry, if we can go back to our speaker slide. So Dr. Rodeo is an orthopedic surgeon specializing in sports medicine. Dr. Rodeo also serves as the director of the Center for Regenerative Medicine and as the head team physician for the New York Giants football team. Dr. Rodeo's clinical expertise lies in orthopedic sports medicine, specializing in intricate knee reconstruction, as well as advanced tendon repair in various joints. Dr. Ashley Austin is a primary sports medicine physician and former Division I basketball athlete. Dr. Austin has covered sports at all levels, including high school, National Ski Patrol, the WNBA, and Major League Baseball. Beyond her medical pursuits, she enjoys high-altitude mountaineering, hiking, playing sports, and engaging in creative activities like reflective writing. Dr. Sheeraz Qureshi is an orthopedic spine surgeon and co-chief of HSS Spine. Dr. Qureshi is a leader in the field of minimally invasive and motion-sparing spine surgery. His major research interests include minimally invasive spine surgery outcomes, cost-effectiveness, and comparative treatments. Dr. Qureshi is renowned for his global efforts and contributions to the international surgeon education. Dr. Edward Yoon is an interventional musculoskeletal radiologist specializing in novel, minimally invasive treatments of the joints and spine. He has a strong interest in regenerative medicine and interventional procedures. Dr. Yoon has contributed to numerous research projects and has presented on the largest intradiscal stem cell therapy for degenerative disc disease. Thank you to all of our panelists for joining us, and I will turn it over to Dr. Rodeo.
Thank you, Pamela. Well, welcome, everyone. It's a pleasure to be here and to thank my colleagues for coming on. This is just disclosure for the research report that runs my laboratory. As Pamela mentioned, I'm an orthopedic surgeon. I also run a laboratory here, and we do a lot of laboratory work related to regenerative medicine. So this is our research support here. I'm going to move ahead here. So certainly, many of the orthopedic tissues that we deal with have inherently poor healing potentials, relates to injuries to cartilage, meniscus, bone, tendon. You see pictures here of a meniscus tear, a cartilage injury in the middle, a tendon tear in the shoulder below there. And this has led to a real explosion of interest in approaches to augment the biologic events that lead to tissue healing and tissue repair. For example, we need cell proliferation, we need new blood vessel formation, cell migration, and ultimately new tissue synthesis to regenerate and heal these inherently difficult to heal tissues. And this brings up this area of regenerative medicine. You'll also hear the term so-called orthobiologics, and this encompasses things we'll talk about tonight. One is blood-based therapies such as platelet-rich plasma. We'll talk a bit about cell therapy approaches, and the term stem cells often used. We'll see that frankly, is often a misnomer. This area has tremendous potential, but certainly needs further development, and that's what we are doing here at HSS in our Regenerative Medicine Center with linked clinical and laboratory studies. Where is this field in 2024? Well, certainly an area that has tremendous potential in orthopedics and musculoskeletal medicine. But I would submit to you that the clinical use of many of these therapies has somewhat outpaced the current scientific and clinical evidence. There are frankly many false claims for unproven therapies that you'll see out there. There is very aggressive marketing in this area. And frankly, we're seeing sometimes indiscriminate use, which may, indiscriminate use of unproven therapies may actually hinder progress in the field. So we hope to set some good information tonight, dispel some of the myths and maybe misinformation that's out there in this area. If you follow this whole area of biologics in the popular press, you'll see things like this that have been in the press in recent years. The FDA has taken an active stance and frankly started to crack down and discipline unscrupulous companies and commercial entities that are manufacturing unproven or unapproved products. So again, our goal is to bring some science to this area and some rational information. So what are we talking about in this whole area of regenerative medicine? I'll give you a brief overview here that we'll talk more about in our through this talk as well as in our questions. So we can start with PRP, platelet-rich plasma, which is prepared from a simple blood sample taken from a simple blood draw from the patient. This blood is then spun down in a centrifuge, which isolates and concentrates platelets plus other cell types, as well as a number of different proteins outside of just from the platelets. Platelets contain a very large number of proteins and growth factors. Actually, PRP is very highly complex. The mechanism of action of PRP seems to work via decreasing inflammation. We know that the different proteins and anti-inflammatory molecules in PRP interact with immune cells. It's the immune cells that are involved in inflammation, and often that's what causes symptoms and pain in joints. PRP also has some role in affecting cell proliferation and new tissue synthesis and things like that. So real potential here for PRP to have value in these difficult to treat tissues. Beyond just PRP, if you follow this area, there are other blood-based options, and I'm just going to list them here for you to give just a brief overview. So again, we start with PRP, but you will see others out there. And for the sake of completion, I'm not going to go into any detail on these, but just to make the point, there are a number of similar but somewhat separate blood-related processes that are out there. They're all a bit distinct, but they're all drawn from blood, and there are different processes out there. Note that the FDA approves the devices to spin down blood and do things, but there's no FDA-approved PRP therapy. These things are used widely. I would note the one in the middle called autologous conditioned serum. You may have heard of Regenerative or orthokines is another PRP-like process. It's different, different than the standard PRPs we do, but just to give you a sense of the tremendous variety of treatments that are out there. We're going to focus tonight really on PRP, which is kind of representative of this whole class. Beyond blood-based options, we'll talk about cell therapy, quote-unquote stem cells. The cells that we as clinicians can use today can be derived from bone marrow, from an aspiration from bone, typically from the iliac crest in the hip. We can use cells derived from adipose tissue, from a lipoaspiration or liposuction. There are cells in fat. And so-called perinatal tissues, or we use the term birth tissues. This is cells derived from amniotic membrane, placenta, umbilical cord bloods have been used. I'm going to mention this again in a moment, but I'll mention up here an important point that these perinatal tissues now can only be used in an FDA-approved clinical trial. So there's still some practitioners using these in the community. Be careful; they shouldn't be used since a directive from the FDA in May of 2021. I would submit to you that we have nearly no ability to use quote-unquote stem cells. So what do I mean by that? Stem cells are highly specialized cells that can produce any cell in the body. So a true stem cell can differentiate into a number of different cells. The number of true stem cells by any cellular, molecular, or real functional criteria in these formulations I just mentioned is vanishingly small. Now, that doesn't mean we don't have cells we can use, and I'll mention that here. But understand that the currently available cell preparations that we use are very heterogeneous. They have undefined properties. They're often poorly characterized, and this is what sets us up for the need to do the ongoing research. But there are cells we can use, and there's value, as you're going to hear tonight. But a better term is to use the term connective tissue progenitor cell. We know that bone marrow and adipose tissue, fat, do in fact contain a population of cells that can, in fact, produce anti-inflammatory molecules. They can stimulate tissue healing. But these aren't a true stem cell. These have a somewhat more limited repertoire, a little bit more limited potential than a true stem cell. But these are the cells that we're talking about when you hear about cell therapy and the things we'll talk about this evening. I mentioned these birth tissues or perinatal tissues derived from either amniotic membrane, amniotic fluid, placental tissues, umbilical cord bloods have been used. These are all, of course, allogenic. That means they're donor tissues. Of course, they're not from you. They're not your tissues, of course. In fact, these materials do contain some anti-inflammatory mediators that can affect symptoms, but understand there are zero stem cells in these materials. And as I mentioned, they're currently off the market and can only be used in an FDA-approved clinical trial at this time, of which there are some ongoing trials. How do these work? Well, we could have a whole nother hour lecture on the biology. This is something we study in our laboratory, but some brief points to give you a sense of why we use these treatments. They are certainly very, very complex at the cellular and molecular level. The basic mechanism of action of many of these materials, though, is the presence of a number of anti-inflammatory proteins. They can modulate the excessive inflammation that we know is present in many injured joints, certainly in arthritis, chronic tendon problems, chronic spinal disc problems. Inflammation is one of the fundamental abnormalities. We also know that these things we inject have very important interactions with the local cells in the joint. So we put in PRP from blood or cells from bone marrow or cells from fat. They produce a plethora of various signaling molecules that then affect the cells inside your joint. So if we inject it in your tendon, we're affecting your tendon cells or the cells inside your muscle or the cells inside your spinal disc. Truly, there are a number of unanswered questions about PRP and cell therapies, and against what drives our laboratory work, which is linked with our clinical registry as well. Some other thoughts here on just how these might work. Current data suggests that these treatments can, in fact, improve pain. But really, we have less data to suggest true tissue regeneration. So it's certainly fair to say that these treatments are symptom modifying, but less data to suggest that they're truly always structure modifying. Can they truly regenerate tissue? We're working on that, and that's kind of the next generation of these materials. A fundamental question in this whole area, as we go through it tonight, keep in mind, is the tremendous heterogeneity. What are we really putting in the patient? Quite simple example here. We take a drug, that's a precise composition and known concentration. That's very different than a sample of your blood or your bone marrow or your cells from fat. There is tremendous variability in these different formulations. And this variability has led to tremendous heterogeneity or variability in the clinical outcomes of these treatments. We understand what we need to do is identify the composition and the biologic activity of a given dose, and then correlate that with the clinical outcome. And that's what we're trying to do here at HSS, so we can really learn what is the best treatment for a certain patient, for a certain tissue, how to move this field forward. And that gets to the issue of precision medicine, which kind of the mantra of precision medicine is, you see here in the first bullet point, the right drug, the right patient, at the right time. What this means is, one size does not fit all. The same PRP batch wouldn't be expected to have the same positive effect on a tendon or a muscle or a spinal disc or meniscus. So they're all very different tissues. We need to determine the optimal treatment for specific conditions, all these things I mentioned, and for each specific patient, and ultimately match the two. Regenerative medicine treatments certainly really fit in this whole area of precision medicine, and there's tremendous potential here in this whole area. So where might we use PRP these days clinically in our patients? So there's good data to support the use of PRP for treating the symptoms of knee osteoarthritis, for pain and swelling. There's good data on use for tendon problems, rotator cuff problems, maybe tennis elbow, Achilles tendon, patellar tendon. A lot of the data is somewhat mixed. As I mentioned, there's a lot of heterogeneity and variability in this field. And so we see some variable results for different tendons. There's the potential for these therapies for degenerative disc disease in the spine. We'll hear more about the spine from my spine colleagues here. I've used these modalities as an adjunct to rotator cuff repair surgery intraoperatively, as well as an adjunct to meniscus repair to try to improve healing of these difficult to heal tissues. And we can hear more from our spine colleagues on the potential surgical use during spine surgery of these various regenerative medicine approaches here. Harvesting bone marrow or adipose tissue requires some analgesia, and it takes careful sterile technique. These diagrams below show putting a needle into the iliac crest and the pelvis, where we often harvest bone marrow. One on the right shows an aspiration of fat, liposuction here. This is usually done in a special procedure room or an operating room. Most commonly used as a surgical adjunct at this time, but there certainly is great potential to start to use these treatments non-operatively in the clinic, and that's what we're working on here in our Regenerative Medicine Center. Which brings up just a summary slide of what we are doing here. The overall purpose of the Regenerative Medicine Center here at HSS is to advocate for the responsible use of these biologic therapies in clinical practice. So we collect clinical data and laboratory data on patients that are treated with these various treatments. We have a parallel laboratory and clinical studies that go on. Our overall goal is to report on the safety and the efficacy of these biologic interventions for different orthopedic musculoskeletal conditions, with the ultimate goal being to identify the optimal regenerative medicine approach for these various musculoskeletal conditions. I'll just leave you with one last slide on some emerging approaches because it's an exciting and rapidly growing area. we are learning that we can stimulate the intrinsic stem cells that are present in many tissues. I mentioned the use of cells. I mentioned the limitations in our ability to really call these a stem cell, where there are, in fact, intrinsic stem cells in many tissues. We're learning now, how can the treatments we use leverage those intrinsic cells? And second area is there's been identification of skeletal stem cells within the body. This is some work from Stanford University, from some very sophisticated work. We're learning the ability to eventually stimulate these intrinsic stem cells. So this is kind of the future of this whole area. So with that, we think we can go to our moderated panel discussion. I will stop sharing here. Are we back on screen?
You are.
Okay, so you have a nice introduction to my colleagues here, Dr. Ashley Austin, Dr. Ed Yoon, and Dr. Sheeraz Qureshi. We start with Dr. Austin. We've seen that there is now good data to support the use of PRP for knee osteoarthritis. In particular, there are now studies demonstrating that pain relief can be superior and frankly longer lasting than that we see with these gel injections or certainly steroid injections. What are your thoughts about using PRP for osteoarthritis in other joints, maybe the hip or the ankle or the shoulder? Can we extrapolate from the knee?
Yeah, of course. So as you mentioned, yes, the best data we have is for the knee. And as we know, we see patients all the time that are coming in for problems with the shoulder, the ankle, the hip. And, I think our knee-jerk reaction is to extrapolate those results and say, hey, maybe we can get similar results in those other joints that we see patients coming in with pain in so frequently. However, there are studies in each of those joints, the hip, shoulder, and the ankle. And to date, there really, again, is pretty mixed results. There isn't any consensus that PRP in any one of those joints is really helpful and really improves outcomes in the way that we've seen it in knee OA.
Yeah, no, thank you. When using PRP for knee OA, is a series of 3 injections better than a single injection? You might even comment here with that on the practicality and cost issues associated with obviously 1 versus 3 injections.
So I actually get this question a lot in clinic, and I know historically there are people that I've seen who have had PRP injections before, and they're coming in. Let's say they moved to town and they were somewhere else, and they mentioned coming in for a series of 3, stating maybe they got that previously, and they wonder what the difference is. And what we know is there actually isn't great evidence to suggest that 1 injection is inferior to having 3 injections. And so what we tell those patients is, number one, it's an actual cost benefit to them because, as you know, the PRP is an out-of-pocket cost to patients. And so a lot of them are very excited to hear that they don't actually have to come in 3 times and pay 3 times. So it is more cost effective. So I don't know any of my patients that are upset to hear that news. And secondarily, I just with any procedures that we're doing, there are risk of side effects. There are risks of infection. I think we kind of simplify injections as we're just doing an injection, but I really, there's a risk with any time we're doing a procedure. And so being able to mitigate that risk by only needing 1 injection is great for patients.
Well, that's important. I think you make the important point of educating our patients. Realistic expectations, critically important. And in anything we do in medicine, but it's probably no more so than this area of some of these evolving treatment options. I'll say to the group that we'll monitor your questions coming in, but given the large group here, I think we're going to have some prepared questions that will, I think, address many of the important issues that you'll ask about. Dr. Qureshi, on the spine surgery side, we've just been discussing how PRP can help symptoms of arthritis. How about PRP for pain in spinal conditions? Is PRP injection better than, say, an epidural injection for nerve pain?
Yeah, thanks, Scott. I think the evidence, similar to what we just heard from Dr. Austin, for knee is uncertain right now in the spine. I think there is some reasonable literature out there looking at the impact of PRP for degenerative disc disease as well as for herniated discs. There's some case reports that suggest that using PRP in the epidural space when there's a disc herniation can be as good as an epidural steroid injection. But that being said, I think the literature is sparse. Most of it is level 4 evidence. And so it's hard to say that it should be used in place of an epidural steroid at this point for a disc herniation. And in degenerative disc disease, it really depends on when we're catching that patient. And again, the evidence right now is primarily level 4 evidence in the use of PRP in patients with degenerative disc disease. That being said, the results are promising.
Yeah, that's helpful. And this also points out the need for rigorous research. And that's, in fact, I think what we're trying to do here at HSS. And my role as Vice Chair of Research is to really improve our ability to do high-level clinical research, intervention trials, so we can start to move this field forward and answer some of these important questions. Dr. Yoon, continuing to speak about the spine, can PRP or, frankly, cell therapy relieve pain due to degenerative disc disease?
Yeah, as Dr. Qureshi mentioned, there has been some randomized control trials looking at PRP as well as injection of either allograft or mesenchymal stem cells into the disc. And, there is some promising results where there is reduction in pain, but a lot of these studies, the control where the patients are in a non-treatment arm is able to cross over to the treatment arm very early on the study. And on top of that, when compared to injecting normal saline, which is considered, the quote unquote a sham group, it doesn't seem like it outperforms it in a statistically significant way. So there is overall pain reduction, but it doesn't seem like it's beating out normal saline. So that's kind of a challenge for a lot of these studies.
Dr. Austin mentioned the potential for infection with numerous injections. Same thing on the spine for Dr. Yoon. What are the potential complications with injecting these quote unquote biologic agents around the spine? When you think about spine, many of us kind of go, "Ooh, spine, nerves and important things." Not that the knee's not important, but what about the spine? What are the potential for complications?
Obviously the most feared complication would be the discitis and infection, where a surgeon would actually have to go in and get a clean out. And, working in the spine like that is way different than cleaning out a knee. So it's really, really a feared complication for us, albeit, and even in these clinical trials, there's always a 1 or 2% of patients that get these, osteomyelitis or discitis. So we certainly have to use these therapies, and we certainly have to be certain that this therapy will help the patient instead of just sticking the needle in, because there are, certainly dire consequences. It's not just an injection by any means.
Which I think brings up the important point of how these treatments should be done in a responsible fashion with, appropriate surgical or sterile support, appropriate sedation sometimes, and careful patient follow-up, but it's critically important. Back on kind of on the spine, there's still Dr. Qureshi. Beyond PRP, we obviously have various cell therapy approaches that might have great potential in this area. What data do we have in the spine literature comparing the efficacy of, say, bone marrow-derived cells versus maybe fat-derived cells, adipose tissue, in spinal applications?
Yeah, so in spinal applications, when we think about stem cells, there's some different uses. As Dr. Yoon just suggested, there is this thought around stem cell injection intradiscally for a patient with degenerative disc disease. There's some early studies coming out looking actually at discogenic cells, which are allogeneic disc cells that have been donated and are being engineered. Specifically with regards to stem cells, probably our best literature, even dating back now going close to 20 years, has really looked at the use of stem cells in augmentation of more traditional surgeries like spinal fusion. And there's been a comparison looking at bone marrow-derived mesenchymal stem cells versus adipose-derived stem cells, which are sort of fat that's taken. And the literature actually is quite supportive of the use of stem cell for augmentation, especially adipose-derived stem cell. That being said, whether or not it's actually better, like Dr. Yoon was just saying, compared to not using it, the statistical significance has been difficult to show. But certainly from a safety perspective and augmentation of spinal fusion, it is there's certainly a role for it. But in terms of replacing more traditional procedures like decompressions and fusions, I think the role of stem cell still remains in question.
You bring up the important point of the potential for these these treatments to be used as a surgical augment, right, for augmenting healing. So not just using it as a standalone. There's standalone treatment for non-operative treat care or injection. And then there's the surgical augmentation part. Dr. Austin, let's kind of shift gears for a moment here. How about using regenerative medicine treatments for chronic tendon problems? Should we use different orthobiologic agents for different tendons? And can we expect the same, say, PRP formulation or cell therapy formulation to have a positive effect on such different tendons, on Achilles tendon or a rotator cuff or tennis elbow?
Yeah, so I think this is a great point to make, just because all things are not, kind of like I mentioned before, all things are not created equal. So just by showing benefit in one area doesn't mean we're still going to get that same benefit somewhere else. So similarly, the hallmark, sort of one of the hallmark studies for NEOA, as we know, was looking at leukocyte poor versus leukocyte rich PRP, and we found that leukocyte poor, meaning the PRP we were injecting had less than the baseline level of white blood cells, which are thought to have some, inflammatory effect. Leukocyte poor did better than leukocyte rich, but I think we take a little bit of a different approach when we're looking at things like tendons. So for tendons, the literature that we have so far does not suggest that leukocyte poor is what we want to use, and in fact, leukocyte rich PRP is generally an option to use as well. And so when I think about things like patellar tendons, that there's some pretty strong literature that leukocyte rich PRP does work well in patellar tendons, but there are some Achilles tendon studies that show that there isn't much benefit from injecting an Achilles tendon. I think the literature is variable with that. Similarly with the rotator cuff as well, the literature is pretty variable. So I don't think really all of these locations are the same. I think one of the other ones I run into is like plantar fascia for plantar fasciitis or plantar fasciopathy for that chronic pain. And there was one study comparing steroid to actually PRP, and what they found was that the PRP was marginally better than steroid over time. So I think that's important to note is I wouldn't consider PRP as a magic thing, like this whole concept of one size doesn't fit all. So I think we really have to be diligent and intentional about how we're choosing patients for this. And the other thing I would say is, we talk about all these therapies, but certainly, we're choosing appropriate patients for this. And a lot of these patients have done a lot of the conservative management for these things. So they've done physical therapy, they've done all the things. This is generally, I wouldn't consider these like first line therapies. We're seeing a patient for the first time. There's a lot of thought that goes into this, and I think that's important to relate to patients.
I guess that's important. It's an area that clearly needs further investigation, especially for different tendons are so different. The tendon in the shoulder may be different than tendon in the knee and different than the tendon in your ankle, right? And they're different biologic environments, different mechanical environments, and that's why we need to continue to follow what we do rigorously, collect our data. Dr. Qureshi, the real allure and maybe attraction of regenerative medicine might be not only to treat symptoms, but to actually regenerate new tissue. Going back to the spine, can PRP or cell therapy improve bone healing? Can we actually not just treat the symptoms, but can we improve tissue healing? Can we improve spine fusion?
Yeah, thanks. I think that is an area that has been looked at in several studies. Both PRP and stem cell have separately been looked at, not compared against each other, but compared to traditional fusion. Early on, the thoughts around PRP were that it can actually have the potential to inhibit fusion by creating a significant inflammatory response that can actually prevent bone formation. But some of the more recent studies have shown that especially higher concentrations of PRP placed intraoperatively can have a positive impact on bone formation. With regards to stem cell, again, bone marrow-derived stem cell is a commonly used augment that we'll often take at the time of surgery, a bone marrow aspirate, and augment our fusion with that. And that has also shown some good results. And there's a lot of interest around adipose-derived stem cells. And in direct comparison in some literature out of Europe, that looks at adipose-derived stem cells and mesenchymal stem cells from the bone marrow, comparing them in spinal fusion. Adipose-derived stem cells tend to show an even higher volume of bone formation. A lot of these studies are right now in an animal model, and then there's some, retrospective type of clinical studies that have been done. But I think that the results in augmentation of traditional fusion is promising.
That is promising data. That's sure an area of ripe for further investigation too. Then, Dr. Yoon, continuing on this question of whether regenerative medicine approaches can actually regenerate tissue, does MRI, as a radiologist, does MRI show changes following injection of these materials? Are we actually regenerating tissue that we can see on an MRI scan or an X-ray or a CAT scan, so we can kind of follow the outcome of these treatments?
Yeah, so there's only been one study that actually looked at the MRIs before and after injecting PRP. And it seemed like, different MRI signals show up on MRI. And one of the hallmarks that we use for degenerative disc disease, just like we lose water from our skin, which is why we get wrinkles, it's the same in the disc. So as we lose water, we get degenerated discs. And, they were looking at whether the water signal kind of increased after the intradiscal PRP. And there's only been one study that looked at this, and it doesn't seem like it changed the signal. And the part of the discussion, I guess, goes back to, okay, we know we're not regenerating tissue here, but the patients are feeling better. And I feel like for now, that seems to be the first kind of goalpost that we're aiming at.
That's helpful. Yeah. A critically important area, part of the whole discussion is the current regulatory environment and what's allowed and what's not allowed, especially when you get to cell therapy formulations. We've mentioned bone marrow. We've talked about cells from adipose tissue. The current regulatory environment in this country does not allow us to take those materials out of the clinic or out of the operating room and take them to the laboratory and do cell sorting and cell culture expansion. Now, those things can be done in some other countries, but the regulatory environment here does not allow us, that's quote unquote what the FDA calls manipulation. So as such, the regulatory environment has tied our hands a little bit, and for good reasons. There's issues with sterility and chain of custody with specimens and things like that. But there's great potential in the area we can actually take these cell formulations, these materials, bone marrow or adipose tissue, to the laboratory. We can isolate the desired cells, and importantly, eliminate the undesired cells, because that's an important part here, and then expand those cells in culture and then re-inject those into the patient. Again, we can't do that yet in this country. And the question I would ask my colleagues here is, and if we get this question a lot from our patients, whether they should go overseas for these regenerative medicine treatments, where they can pursue some of these treatments that aren't available here in the United States at this time. I get this a lot from my athletes. Individuals will go to the Caribbean, to South America, places in Germany. It's hard to answer these questions. It's hard to know what's really being done in these centers. Dr. Austin, what do you tell patients when they ask you, doctor, should I go to, the Bahamas for this treatment, or it's Colombia, South America?
I definitely caution my patients that are asking about this. I mean, I think, you mentioned just, 5 or 6 countries right there. And, there's a long list of countries. And I think it's really hard to know how these countries are regulating things. And ultimately, we are really, what we really care about is safety and patient safety. And I think it's really hard to follow that with so much variability in the locations where people are getting it, and that there's not great oversight with making sure, that how people are getting these things are reproducible, safe. And so I really do caution patients if they're doing that. And I just say, it will be hard to know what their outcomes will be. And it's long, and so I think certainly patients have the opportunity to make their own decisions, but it is quite difficult for us to predict what their outcomes would be based on so much variability.
Yep. Now, job as physicians is to simply educate our patients best we can. Dr. Qureshi, do you get that patient on that question from patients on the spine side, and how do you deal with it?
Yeah, I mean, it's an incredibly common question, and I think it's a very reasonable one. I generally always start with the line, hey, if it sounds too good to be true, it probably is. So, you know, be careful of where you're going. That being said, you know, what my general advice is, research the clinic, make sure that you have a good feeling about the medical staff and verify the legitimacy. And I use it as an opportunity. You know, I think a lot of what I myself am learning about what other people are offering is from patients coming in and asking me, hey, I heard that there's this great clinic in Panama that I should go to and have stem cell done. But I think you know, like you were saying, it, you know, for very good reasons, you know, we can't do certain things in this country that are available in other places. But at the same time, I think you know, safety should come first. And then the cost, you know, equation is totally separate. These stem cell therapies can be extremely expensive. So if we can sort of get past the clinical part and say, okay, maybe this is a good option, maybe, then you have to make that decision around whether it's a cost-effective option for you. So I think it's a lot of layers there.
No, that's an important point here. These are all, you know, kind of, they're not approved by insurance, no, they're not covered by insurance. And so there's often is that cost issue. I get these, had two NFL athletes in the last, you know, 4 or 5 weeks. Same way, one go overseas. And I think it's important to note there are just wide variability as you both nicely laid out and articulated. There's some of these kind of fly-by-night clinics that you don't really know what they're doing. And then there are real legitimate places, you know, in Korea, in Japan, these treatments are quite advanced, and they're in the clinics more. The regulatory environment's a bit different, but they still have very strict and rigorous post-marketing surveillance. There's good treatments being done, so and we're learning from our colleagues overseas. So these are not all unreasonable. They're not all indiscriminate, but it's just hard to know. It's just hard to evaluate them without having, you know, rigorous data to help guide our patient. And again, it's back to comes down to basic research, laboratory research and clinical research, and really linking the two. I looked at some of the questions here in the chat to kind of go through some of these as we get near the end here. There's a number of individuals. A lot of questions came up about arthritis. You know, will PRP allow me to avoid a knee replacement? Will it fix my thumb arthritis? What we've seen, and certainly the knee, and other joints now too, but especially knee, there is good data to support that PRP can improve symptoms, as Dr. Austin went through nicely. Yeah, we're not regenerating tissue, so we're not regenerating cartilage. So can it avoid a knee replacement? Maybe, but not likely. These are symptom modifying. They're not going to reverse the arthritic process. At the end of the day, if you found a PRP or any injection for that matter, gel, same way, gives you long-term relief and you did it once a year, fine, you could avoid replacement. It's all kind of, you know, back down to symptoms. There's questions here about gel injections, which are commonly used, so-called hyaluronic acid, a number of different brands that are out there, versus PRP. There is now some pretty good data, rigorous, well-done, randomized trials demonstrating that PRP can be more durable, more effective than hyaluronic acid, than these gels. Again, a lot of variability out there, but there is good data to support that. Now, the gels are often covered by insurance. PRP is not. So again, you get into these cost issues. And I think our job, again, as clinicians, is to educate our patients about, you know, realistic expectations, because patients sometimes pay for these treatments out of pocket, and they're not great because they're variable, the outcome. So it's an important point. But to these questions that have come up, there's good data to support PRP for symptom relief, in particular in knee arthritis. Switching gears a little bit, there's some questions about muscle, and Dr. Austin, as a sports physician and a former high-level athlete yourself, I'm sure you see lots of muscle injuries, as do I, hamstring injuries in our football players. What are your thoughts about using PRP for higher grade muscle injuries?
So PRP and muscles, you know, the way I sort of think about it is acute muscle injury. So I've had some patients ask, you know, they've had an acute muscle injury, you know, are they a candidate for PRP? And I think I really go back to what I say is, like, you know, we're generally doing our usual standard of care, which is things like physical therapy, which is things like, you know, a progression. And those things generally get our athletes back to where they want to be. You know, I think there's sometimes a misconception that everyone gets PRP, you know, if you're at a collegiate or a professional level. But I think, again, we really want to make sure we're choosing patients appropriately. So there isn't any supporting evidence for doing, you know, PRP and acute muscle injury. And, PRP certainly can be considered for things like, hamstring, chronic hamstring
Yeah.
pain, especially proximal hamstring pain, because we know, those are very tough surgical procedures. And additionally, things like chronic gluteus tendinopathy, which we see a lot. So gluteus, the tendon as well. There's some pretty good data for PRP on those patients, but those are pretty select patients, and those patients very specifically have failed all the other, conservative management usually, because PRP, again, I don't really think about it as a first line therapy. So it's really supplemental to all the other things people do to get better.
I think that's a good point about the hip tendons, gluteus medius, and there's some questions here in the chat that's important, that's, it's an option, like we see it for all these different tendon problems. I think that's, and you also made an important point about it, seeing these things, not your first line treatment. I would agree. In your most common thing we see, arthritis, I see shoulders and knees, and, you often start with a simple steroid injection, and then maybe you go to a gel injection because they're reasonable. Now, the data on gels are mixed at best, but they're safe. They can be helpful. Not a lot of downside. We don't have other great options. And so we often kind of do it in this graded fashion. Then you go to a PRP. I think that's kind of good clinical medicine or responsible medicine. You can certainly jump right to PRP, but you have to, weigh the cost issues and things like that. So Dr. Yoon, as the radiologist, talk to us about imaging. Should we do our injections always under imaging guidance? Clearly someone's paying, money out of pocket for these treatments, and I'm going to inject it somewhere. They want to be sure I put it in the right spot. So what are your thoughts on what are the best ways to do these injections using your skills and in imaging?
Yeah, I mean, especially since PRP and some of these cell therapies are going to be out-of-pocket expenses where it's extremely expensive, I would advocate that an imaging be used to make sure that the very expensive procedure that you're paying for and cells are going into the correct location. So when it comes to spine, we normally use fluoroscopy, where it's a lower powered kind of X-ray beam. So we kind of guide our needles that way, and obviously around the extremities. And I know Dr. Austin uses ultrasound for the extremities.
Yes.
I think it's essential. I think if you're going to these clinics where they're injecting blind into muscle and saying that, oh, I'm in the sacroiliac joint, or oh, I'm doing an epidural injection, I think you should be very wary about that.
Again, I think it gets back to, doing these treatments in a responsible fashion with the appropriate, resources, appropriate facilities. And then not just doing the treatment, but following that patient. Let's learn from our patient to see, what works, what is the optimal treatment for different patients. But I think is really the next frontier in this area, is identifying, again, that precision medicine approach. What's the right treatment for the right patient? We can match, this same PRP formulation shouldn't be expected to have a positive effect on tendon, on meniscus, on bone, on, spinal disc. Those are all very different tissues. I see a question here on plantar fasciitis in the foot. That can be a real nuisance. We all see that sometimes. Dr. Austin, have you ever tried PRP or any of these things for plantar fasciitis? I haven't myself.
I actually have, and there are a couple studies suggesting that PRP can improve outcomes in these patients, but typically the studies that have PRP, these patients are doing a lot of other things. So many of those studies, patients are doing they're doing physical therapy. They may even be doing something like wearing a night splint, which may be helping with them as well. And so I think I've never come across it in a study as a monotherapy. Usually it's in conjunction with other things. And as we know, plantar fascia is really tough to treat, and it can stay around for a long time. So I think it certainly is an option, but it's usually on the further end of my options after I've exhausted others. I alluded earlier to a study that specifically looked at PRP versus a steroid injection. And PRP did marginally better than steroid. So I think, again, we have to make sure we're choosing these patients correctly. I think in this case, MRI and ultrasound, both are super helpful to make sure, of what you're injecting before you inject it. Some people have plantar fasciitis and that's all they have. And some people actually have some underlying, partial tears to the plantar fascia, and they have a lot more damage. So I think it's important to map out appropriately what you're injecting before you do it.
Well, that's important. Again, Dan, what are you injecting? Again, back to my slide earlier, that one of the truly most fundamental underlying questions in this area is the variability in identifying or what we're putting in the patient. Because you make PRP today from you and make it tomorrow, it'd be different. And there's studies that looked at that. So take the same patient, same blood, draw the blood, then characterize the PRP, all the different proteins in it, and they're different. So it just shows how complex this is, which gets to our research need and goal is to characterize what we're putting in the patient and identify what works, what doesn't work. Because I think if we all hear, as we go through the studies that you're all nicely citing, you talk about the variability and the heterogeneity in the outcomes. And that's because we just, there's such variability in what we're actually putting, into our patients here. So that's an important point that's come up here. There's some questions here about, regulatory hurdles and why can't we do these things in the United States? And it's a long answer. There's a lot to go into in that area, but the regulatory environment here is based really on patient safety. So again, as I mentioned, inability to take bone marrow or an adipose formulation and outside and do cell culture and everything is because of the need for careful sterility. How the cells need to be handled appropriately. They can change their biologic activity when manipulated and cultured. Certainly simple chain of custody. You want to make sure you get your materials back. That relates to sterility issues. So it's very complex, and these can be done. You need a so-called GMP, good manufacturing practices type of facility that does these things. So, and these can be done under FDA-approved clinical trials, and we'll be doing some of these trials here at HSS. There's a couple going on around this country, so they can be done, but they need to be done in that fashion here. And that's, as I mentioned before, it gets to the issue of why some individuals go overseas where these treatments can be done here. I see a question also on shifting gears a bit, but it relates to regenerative medicine, and I'll bring it up because it's about these so-called peptides, BPC 157, which is a mixture of these small peptides that's been out there marketed for kind of tissue regeneration, and we'll talk about it. I'll ask maybe Ashley if you can comment on it, but more broadly, it brings up the issue. We've talked here about PRP and cells. Well, regenerative medicine encompasses a lot of other approaches, frankly, that we're starting to investigate in our laboratories here. For example, gene therapy approaches will fit in this area eventually. Novel drugs are being developed. Novel small peptides are being developed. So gene editing techniques they're all in investigation right now. We're not there clinically, but this point being, this area has tremendous potential beyond just some of the treatments we've talked about tonight. But BPC 157, I get asked this a lot by athletes, it's available kind of, over the internet. These so-called quote unquote peptides that are purported to improve tissue healing, for which there is, very, very almost none clinical data or human data. Dr. Austin, your thoughts?
I personally haven't, used any of these products, and I would say that this is something that was newer to me when I moved to New York, hearing athletes sort of talking about it. So I believe at one point we may have been chatting about you mentioning that an athlete mentioned this therapy, but it was new to me. So I'm still learning a lot about this field, but I would say I'm not familiar with it, and I wouldn't be able to, recommend it for an athlete at this point, based on my knowledge on it. But I'm not sure if any of my other colleagues have had more experience with it than I have.
Sheeraz, have you been asked about this?
I have been asked about it. I mean, to me, the concept of a peptide that you take orally being able to cross enough of a cell membrane, it just doesn't seem to make sense.
Yeah.
So I generally have advised that it likely has an anti-inflammatory component, and so it can be helpful. But to actually think that you can have something orally that's going to cross the cell membrane, even these short peptides, it's not something that I recommend.
And Ashley, you made a very important point that said, frankly, I'm the same way. You said, I don't know much about this, and it's hard to advise my patient. Same way. And because there's no information out there, frankly, you and I can always go to the internet just like our patients can. So, we talked about Dr. Google. Patients come in having read these things online, because there is so little rigorous information, it's hard to advise our patients. There is a huge amount of information that's out there, but it's, the quality and the source of that information is often in question. And so I'm the same way. I think that again, it's back to educating our patients, tell them what we know, and importantly, what we don't know. And then, identifying safety. There's some things that the patient may go ahead and try because it seems to be safe. It's in the might help, won't hurt category, and that might be okay as long as the patient goes in, with expectations and they're they understand, but that's all important part of our job. Lastly, the question about, what is the future of cartilage regeneration? Are we going to regenerate cartilage? And so this, relates to this area of regenerative medicine, because a lot of these approaches we've talked about when using cells and gene therapy and signaling peptides has a role there. It's an area we study somewhat in our laboratory, so I can comment. It's an exciting area, tremendous potential, obviously, because it's probably arthritis and one of the biggest healthcare expenditures in the United States. It takes a combination of research involving cell biology, molecular biology, experts in biomaterials, and then linked with clinicians. So I think there's great potential. It's really the combination of novel materials, cells, maybe cells that we modify with genes, and lastly, the appropriate proteins, the signaling molecules. It's that combination. It's kind of the tissue regeneration or tissue engineering paradigm. I would end by saying there's great potential, but we're not there. I mean, it's a very challenging problem biologically and biomechanically. Obviously, a huge number of centers working on this problem, even some research here at HSS. So you see it in academia, you see it in commercial entities, because it's such a huge potential market. So what I say in this area is stay tuned. We're near the end here, so any last comments from my colleagues before we wrap up? I'd like to thank you all for your insight and expertise, and hopefully we got to address some of the questions that come in the chat here. That we have a number of questions, so it looks like there's a lot of interest out there. I'd summarize by saying, again, stay tuned, because it's an area that continues to evolve, and that's what we're trying to do in our efforts here in our center at HSS.
I really appreciate all of your time and your insight. The one thing, there was so much information that you presented tonight, and my mind is spinning, to be honest with you. So I can imagine those that are viewing also have the same. If you were to leave the audience with one parting statement on regenerative medicine, could you each touch upon that one parting statement based on your expertise and perspective?
Dr. Austin, what would you say?
I think I've said this a couple of times, but I really, I think it's important to make sure, to not get lost into these, thinking these therapies are magical. I mean, there's still a lot of work that has to happen for patients, and a lot of, sort of partnership and collaboration for making people better with the different ailments they have coming in. So I think PRP is one arm of this. But it really is usually a multidisciplinary approach, with our therapy colleagues and everyone else to get patients better. So I think again, this is one portion of what we're doing here at HSS.
Thank you. That's well stated. Dr. Yoon, what are your thoughts on from the perspective of a radiologist expert and spine expert?
Yeah, I think one thing I would say is definitely go to a place that keeps track. I think it's so important. I think that's one of the ways that you could tell whether a place is legitimate or not. And then, like Dr. Qureshi said, I'm going to borrow his thing. If it's too good to be true, it probably is not a good thing.
Sure, same thing. What do you think? Yeah, I agree. If it sounds too good to be true, it probably is. That's a good place to start.
Yeah, I would say for the spine especially, I would leave the audience with that we have good treatments for spinal pathology, both non-surgical and surgical. And the hope is that these regenerative medicine procedures and products find a place, probably not to replace the things that we already do, but potentially could be additive or maybe earlier interventions. I think the most important thing is to really have a good discussion with whoever's taking care of you, so that you can feel educated and so that you can make the best decision.
No, that's well stated. In fact, you made an important point there. We have good treatments outside of regenerative medicine. You've got good treatments in the spine. And an important point in this whole regenerative medicine area is be careful that one doesn't pursue an unproven therapy that's risky and delays appropriate treatment. If you have an end-stage arthritic joint that's inhibiting your ability to function on a daily basis, joint replacement works. And don't think that, so I've had patients pursue these regenerative medicine treatments at a lot of cost, doesn't do much because their arthritis is so advanced, where they're delaying frankly, appropriate treatment. So I think you bring up an important point. What I tell patients is, I think I mentioned earlier, these treatments can be symptom modifying, but we don't have as much data to suggest that they're truly structure modifying. The whole term, we talk about regenerative medicine. Well, we almost joke about it sometimes. Is that a misnomer? Are we really regenerating tissue? Well, we hope to. We're getting there. That's the pie in the sky. But frankly, there's a lot we need to learn to be able to do that. And as I mentioned, stem cells. They're certainly cells and therapy has potential. There's a lot of great approaches out there. But be careful on what you told you're getting, quote, stem cells, because the true stem cell is different than the cells we're using. Now we're getting there. And I would say don't throw out the baby with the bathwater. There's a lot that we can learn here, a lot of potential, but it needs further research. So that's what I try to impress upon our patients. With that, maybe we'll wrap up. Thank you all so much for your attention.